Hello, audience. Though I know you are all expecting the wonderful Daniela Daniel next, she will be concluding our case study. I'd also like to give each and every one of you a warm welcome. We know after a strategic planning assessment was conducted by the American Heart Institution, where they analyzed various market share parameters, a decision had finally been made. This strategic planning sparked the possibility of building a new freestanding cardiac hospital. I will be discussing what issues a new building might be able to solve for the American Heart Institution. This center would be designed to support a full comprehensive service line that included prevention, early detection, disease management, and post-op follow-up care. According to an article published in the American Journal of Critical Care by Riddle, Dustin, and Castanas in 1996, they stated that cardiac surgery consumes more healthcare resources than any other single treatment option. It is imperative that healthcare professionals evaluate the traditional methods used to deliver quality care. Due to the presence of a multidisciplinary team, there was an increased quality care in the patient's recovery, a decrease in infection, a decrease in the length of stay, and a decrease in the cost, as well as a high satisfaction rate with patient follow-up. What does this new facility do, one may ask? As proposed, this center would be centralized and offer multidisciplinary advanced programs in one facility, possibly yielding similar results. As Jasmine mentioned in question 1, three major issues were the American Heart Institution poor organizational structure, high mortality rates with valve surgeries, and a lack of uniformity with surgeons' employment contracts. A new cardiac hospital would be the solution to these as well as additional issues. This organization structure would no longer be virtual, and all service lines would be located centrally. This would be working along with Getty's goal to improve standardization and coordination care across the board. Having a solid structure will bring communication between all entities to an all-time high, positively affecting surgeons and procedures. Just as Dr. Cusimano and Dr. Mount were working together, now all of the surgeons will centrally be located, and what makes this better is that they will now be more inclined to discuss surgical tactics and procedures, increasing the success rate of these surgeries. A strong minimally invasive valve surgery program at the American Heart Institution would now be implemented, allowing the American Heart Institution to differentiate from other hospital competitors that do not offer this much safer surgical alternative. Now, everything cardiac related will be under a single budget, eliminating many previous issues. Physician contracts will also fall under this category. Expectations and level of commitment can be reviewed at the time of contract renewal before moving into the new cardiac hospital. One of the new conditions of this contract can be for physicians to commit a new scale of measuring salary based on performance factors. Additionally, an issue with the American Heart Institution was that procedures had become less profitable in recent years. There were increases in cost with the high utilization of costly devices needed. By becoming a freestanding cardiac hospital, economies of scale can be implemented. There can be cost advantages that are obtained due to the size and scale of operation, lowering costs of procedures and medical devices significantly. With an infrastructure built specifically for a cardiac center, geographical issues would now be solved. Everything would be located centrally, allowing patients to find their way much easier. Many community-based cardiologists might not want to refer patients to AHI cardiologists, fearing they would lose them completely to this group. However, a new facility would allow community-based AHI physicians to focus on general and routine cardiac care and leave the specialty treatments to the new hospital. As we can see, this new building would solve many problems, but there are still some underlying issues that still could possibly plague the American Heart Institution. The outmigration of patients and decrease in patient volume may subside with the allocation of all services, but it will not entirely disappear. New patients or former patients who have already moved to competitors might be hesitant new cardiac when thinking about the new cardiac center because it has just opened. They might feel as if there are too many services being offered and could question the quality of care they receive. The American Heart Institution needs to continuously create reports based on collected data to target exactly where patient retention is an issue. In doing so, this will enable them to find out where patients are going and why they are going elsewhere. Many of the cardiothoracic surgery faculty members previously did not embrace the changes Dr. Cusimano made. Much of the current facilities were familiar with one another and weary of adding anyone new to the team. Sadly, it is hard to avoid this. This same attitude might remain despite a new hospital. The old process of following on-call schedules and ordering consultations might continue as most of the individuals train together and tend to follow referral patterns based off of long-lasting relationships. Finally, the habit of surgeons missing conferences or meetings or sending a resident or physician assistant in behalf can possibly continue as this trend. I would like to thank you for your time and attention, and up next is Daniela Daniel with the recommendations of what the American Heart Institution should do now based on the industry standards.